gonna do respiratory and then we'll have a little extra time. So in our little extra time, what we're gonna do is go over, I'm gonna let you guys do these ones together, but I'm gonna do these ones with you. So I'm gonna do the ones after the midterm with you, because I'm gonna post, you guys can work on the ones before the midterm when you're in class here, and I'll go down to the lab early and get our microscope set up. But I will go through transformation again here together. I'll go through Kirby Bauer again, Eliza again, and then we're gonna do these three today. But I could go through a little bit of the math with you too. I was just giving you some examples of the math. But
this is our last lab, right?
This is our last lab.
Okay.
Yeah.
And the lab practical
Tuesday.
is on Tuesday.
Tuesday.
Right on, okay.
Yeah. How's everybody feel about Tuesday? Okay. Okay. Good to know. Good to know. We like to know this. Okay. So I know this seems like a lot, because there's a lot up here, but I bet you can fill a lot in. And the stuff that you can fill in is the stuff that you don't need to study. The little funky clues that you forget are the things that you should study. So what I would do is, myself, even though I'm not really a note card person, for these I would make note cards. I think it's the easiest for, just what's on the front, what's on the back. So on the back, I kind of made like 5 check things to go through. Like, what is the purpose of gram? The purpose of gram is to differentiate between a gram-positive and a gram-negative bacteria. What does their peptidoglycan look like? What does their outer membrane look like? Then that's the purpose. What organisms did we use? Well, that's not really that pertinent. You can use anything. Some of the impertinent ones where we want to discuss the organism are like maybe blood. You can talk about staph and strep are beta hemolytics, something like that. Endospore, it has to be an endospore forming organism. So we talked about Bacillus cereus. So if it's acid fast, we talked about Mycobacterium tuberculosis. So know the organism if it's pertinent to the test. And then you can go through some of the methods, like stab inoculation. We did our serial dilution. How much did we aliquot? Stab inoculation. Here we had the Durham tubes to look for gas. Just those little things that have to do with the methods. And then the reagents, so a lot of them don't have reagents. We have gram, we have reagents. SNOT was potassium hydroxide. I can go through some of those with you. What did we use for acid fast? What did we use for endospore? So then you're gonna have 5 bullet points on the back of your note card, and just flip and flip and flip and flip and flip all weekend. Okay. But I'll go through these last ones with you because we've only done them or talked about them once. And these ones, I know it doesn't seem like they're easy, but you added a reagent and you looked to see if it was positive. And this told you that it ferments and makes an acid. I mean, not super complicated. Transformation, we had to heat shock. Then we looked at the plasmid. What does the plasmid look like? What is the point of a plasmid? So I'll go back through these little tricky ones with you again at the end, and we'll go through them thoroughly one more time. But Dr. Myers sent me the video from the first half review, and we went over it right before our lab practical midterm. So I'll post that. She emailed that to me, and I'll post that. And that was like, I'm super grateful for that, because otherwise I would have just left you to your own devices on the first half. And actually, you get to watch the whole thing again. And thank you, Dr. Myers. So get her a Starbucks gift card by the end of the semester. Okay. Okay. So let's talk about respiratory quickly. Okay. I will go over what alveoli are, but this is a healthy cross section of alveoli. This is a slide. And then here it has an infiltrate, so something is going on. So here, there's a bunch of white blood cells, bacteria, all kinds of stuff that are in the lungs. Pneumonia is a huge problem. If you work in a hospital, if you work in a clinic, you'll see pneumonia cases. But if you work in a hospital, you'll see pneumonia cases all day, all the time. Because when people are non-ambulatory, they're laying down a lot, their lungs just aren't functioning correctly. They're not getting exercise, they're not using their lung, they're laying down and like half resting all the time. Yeah.
And a lot of people have heart problems, and that
Yes.
compounds it because they're not circulating the fluid well.
Yes, that is a huge problem. It's like congestive heart failure, and that can, when their heart's not pumping correctly, and they're not exchanging the oxygen for the CO2 correctly, and then things start backing up, and then once there's fluid in the lungs, then you're in big trouble.
They
So
start
once
swelling.
fluid in the lungs, then it's just a hotbed for bacteria. You basically have like an agar plate in the lungs, ready to grow bacteria. So, yeah, pneumonia is a really scary thing. I always forget the name of that thing. What is the thing where they go and they have to move the ball up and down? I can't remember what the
I
name
want to
of
call
it
it a respiratory meter, but I know it's not.
is. Yeah, I forget what that's called. But what they'll do is they'll give, they have respiratory therapists. So if anybody is interested in respiratory therapy, it's a great job. And respiratory therapists go to patients who are at risk for pneumonia, and they'll help them, give them breathing treatments, and they'll help them get the oxygen all the way to the bottom of the lungs and exercise their lungs, exercise their diaphragm, and so they're getting that fluid out of the lungs, so they're not just sitting. So that is a very important job in the hospital setting. One thing I wanted to ask you guys, I think we might have time on one of the days that I can have my niece talk to us. So she talked to my other class. So I had my husband, who's a firefighter paramedic, and now it was actually, I thought you guys would have gotten a lot out of it because he did a lot of talks about to my other class, to my Biol 100 class, about what it's like to be a first responder. And I think you guys would have maybe gotten more out of it than they would have, just because it was more medical, and he talked about the psychological effects of being a first responder and some of the cool stuff he's seen and some of the hard stuff he's seen. So that was really neat. But also I had my niece talk to her class, and she is an ICU nurse, and so I can have her do a Zoom with us if you guys want, like 10 or 15 minutes or something like that. Okay, awesome. So then you can ask her, like, do you recommend going into the ICU? Do you recommend going into the ED? What is the path to get into the ICU? Should I, do you have any nursing school advice or anything, questions that you guys have? Then you can ask her. She was also a travel nurse for, 4 or 5 years. She was a travel nurse. So if you have travel nursing questions, she splits up half her time between the emergency department and the ICU. So it's kind of cool because that's kind of a unique situation. You either work one or the other, but she likes both. So yeah, any of those questions that you have. So I'll schedule it with her, and we'll get her to talk to you guys. Okay, so upper respiratory, we're just going to talk, keep it simple to the most common issues of the upper respiratory infections. And I'm not, again, going to go over anatomy too crazy. We'll just talk about it, but I won't ask you about it. So obviously the nasopharynx, the mouth and the nose and the throat are probably the most common infections, right? Like, how often do we get skin infections or gastrointestinal infections? Like, not as common as, every third person has a sore throat every once in a while, or sinus infection or something like that. So it's extremely common. And so any part of the upper respiratory, the epithelial tissue of the upper respiratory system can be infected depending on what the organism is, if it's a virus, if it's a bacteria. So it is a hotbed for infection, and that's why we have acids, that's why we have mucus, that's why we have enzymes, things like that, to try and kill organisms, but sometimes the organisms win.
So, just clarification, the left is the anatomy and the right is the illness?
On these
Or
ones? Oh yeah, so the nasal cavity is called rhinitis, so.
If it's ill.
If it's ill.
Infected.
Yes,
Okay.
great question. In the oral cavity, in the oral cavity, there's the sinuses, that really it's kind of between nasal cavity and oral cavity. That's called sinusitis. Pharyngitis is of the pharynx. Laryngitis is of the larynx. So the pharynx is further superior than the larynx. So here's the larynx, here's the epiglottis. Epiglottis is this door that shuts the trachea shut. So that here's where the air goes and here's where the food goes. So the tongue will shut this door that's called the epiglottis, and the food will go down the esophagus. But sometimes there's an infection of the epiglottis itself, is epiglottitis, or it can be laryngitis of the larynx. So here's the pharynx, here's the larynx. The larynx is what included in the larynx is the voice box, or that's called the glottis, and then here's the epiglottis. So you won't be asked about any of the anatomy, but just so you know, a sinus infection, some sort of throat infection, and then epiglottitis is not as common. So they say like oropharynx or nasopharynx or nasopharynx, depending on what's included in, is it just further, like is it the superior part or is it the inferior part or is it both? So they try to differentiate between what is infected and what's not infected. But don't get too caught up on the anatomy. This is what I'll ask you about. I'll ask you about pharyngitis, which is an infection in the pharynx, the common cold, sinusitis, which is an infection of the sinuses, and then acute otitis media, which we've talked about a bunch, which is an ear infection. It does help to read the chapters on any of these. If you just slightly skim the chapters, if you have time, it's a good idea if you're getting tripped up on any of the diagnostics. Okay, so here is viral. So pharyngitis is a sore throat. So when you say I have a sore throat, now we're fancy. We don't say sore throat anymore. Now you say I have pharyngitis. So it's an infection of the pharynx, which is superior to the larynx. So the pharynx, so it's basically a sore throat. That's what it is. But don't get confused either if you see it on a picture or something like that, because there's no Koplik spots. Koplik spots are for the measles. This is just a normal red sore throat. It's 50 to 80% viral. Before this class, I didn't know that. I thought it was maybe more bacterial. It's more likely a virus than it is a bacteria. I'll show you what you need to know.
Do you want us to know the pictures?
Here, this. Yes, know the pictures. And I'll show you what's going on in that picture below. So if it's viral, it's more mild, generally. If it's bacterial, it's more severe. And it can also include a fever. So that's just a broad, you don't take that to the bank, just know if it's viral, it's a little more mellow. If it's bacterial, it's more severe and can lead to a headache. Yeah, fever.
So my question is COVID-19 is viral?
Yes.
And is it just most viral infections are mild symptoms? Because I know that like viral
Such a good question.
COVID-19, you have abdominal pain, headache, fever.
Such a good question. So I think I addressed this in a couple slides, but I can't remember if I did or not. But before COVID, before SARS-CoV-2 mutated and came out, viral upper respiratory infections were generally mild. And then this weird one comes out. So now there's a whole shift in what is viral versus what is bacterial. So SARS-CoV-2 is the funky one. It's the exception where now people lose their sense of smell. They lose their taste. It can also cause nausea. It can also cause pneumonia. It's all these crazy, crazy things from SARS-CoV-2 that wasn't really that common before that. Yeah, great question. So broadly, it's been more mild unless it's COVID. but also it can, you know, if especially if your patient is immunocompromised, or if like elderly patients or small children, you worry about everything. You know, if they're under 5, everything is worrisome. It's not just, oh, it's a virus, they'll be fine. You have to keep an eye on their temperature, you keep an eye on their fluids, you're making sure that they're eating, making sure you have to be really careful for infants, and then also for elderly patients, because something small can turn into something severe really rapidly. Yeah?
On a quiz or exam, if we saw the second picture of the bacterial pharyngitis, and we said tonsillitis, is that diagnostically wrong?
No, that's right, yeah, because the tonsils are there, yeah, you can see the tonsils, Yeah, tonsillitis is correct also. So this is what's funky about strep pyogenes or strep throat, that sometimes there's pus on the tonsils, but not always. So, for example, like my little sister had to get her tonsils removed because every single time she got a little bit of a sore throat, this is what her tonsils look like, big, giant, and pussy. And that's because she's a strep pyogenes carrier, and every time she'd get a mild infection, there's some sort of tissue disruption, there's some other organism in there that's breaking down the tissue, pyogenes would take over, and then all of a sudden she has a pyogenes infection every time. So she had her tonsils removed, and then it's not as likely for her to get such a severe infection from a small sore throat. But this, if you looked at that, you say you have strep throat, it's pyogenes. So that's just something, but also remember, just like the bullseye rash, if there's a bullseye rash, it's Lyme disease. But does that mean you don't have Lyme disease if you don't have a bullseye rash? No. Does that make sense? Yeah? Okay. So same, if you have pus on the tonsils, it's strep throat. If you don't have pus on the tonsils, it might still be strep throat. Yeah.
So when I got COVID, a long time ago, a couple of years ago, the weird thing about it was that my throat hurt really, really bad, and I thought, oh, it's just the COVID, right?
Mm-hmm.
But when the COVID resolved, I still had a group-based strep throat. It's like they were traveling together. They were, the strep A was hiding with the COVID.
Oh yeah, because sometimes that can happen because what the COVID is doing is lysing those cells, and COVID actually can form syncytia. So you remember the syncytia, the big pile of messy cells, the multinucleated messy cells. It forms like a. Do you guys remember the term syncytia? What that means? So there's an infection. So that was one of our cytopathic effects of viruses. So one virus will get in here, and then it will break up these cells and form this big globule, and there'll be a bunch of viruses in here, and there's a bunch of all the nuclei and all of the organelles are all in here in a big giant mess. These cells are not functioning really anymore, and so it's this big syncytia, this big mess, and what they're doing is they're hiding from the immune system. So the immune system is not able to get to them. They're trying to get in here, but they can't. So we're leaning on our CD8 cells to try and destroy and break through this syncytia. But also what can happen is it leaves these cells vulnerable to other bacterial infections. So anytime you have one infection, it leaves those cells vulnerable to a secondary infection. Usually we don't get concomitant infections. We don't get a what's the term for that? Polymicrobial infection. So a polymicrobial infection is when you have more than one microbe as an infection. And that doesn't generally happen because the immune system is already like going. And so once the immune system gets going, then it's already starting to take over. But yeah, but for like HIV patients or patients who are on chemotherapy, immunosuppressant medication, things like that, then they can have polymicrobial infections. Okay, so this is our bacterial source of pharyngitis, viral, broadly more mild, bacterial, broadly more severe, can include a fever because of those exotoxins, are pyrogens. Those exotoxins are turning up the heat. And what else do I want to say about that? Strep pyogenes is the group A strep or gas. Every other kind of strep, like, what other streps did we have in our unknown? I forget. Strep mitis, streptococcus mitis, I think was the other one. So those are everything else is a group B strep. So it's kind of a way to differentiate between this strep that causes the most severe of all the things, and then all the other streps that are not that bad. Okay. So sequelae, you worry about scarlet fever, you worry about rheumatic fever, it can cause long-term consequences, just like coronavirus can. So our SARS-CoV-2 has a lot of sequelae, long-term consequences from having that infection. Sometimes, most of the time, people will get over it, people will be fine. Sometimes people have heart issues, I don't know, gastrointestinal issues I've heard before, things like that, yeah.
Is there any kind of meaningful distinction here between like sequelae and comorbidity with that term as well?
Yeah, so sequelae is like, it's like, let me think of how to describe that term. So comorbidity is like, I have diabetes and I also have cellulitis. Sequelae is, I had COVID and now I have heart issues because I had COVID. Does that make sense?
So it's like it leads to the other, but
Yeah.
comorbidity is like you just have a higher chance of
Yeah.
both.
Yes, yeah, because you have one thing, then you have another, because this one lowered your immune system.
Are sequelae comorbidities also, but not vice versa?
You wouldn't really call it a comorbidity, you'd call it like, it's like caused by that, it's like the consequence of that. Yeah, great question. I just want to throw this out here because I actually saw this on a tease test as well. This Fusobacterium necrophorum is I've seen that on a tease test, but I'm not going to ask you about it. But it's a new worrisome bacteria I've read on some article somewhere that it said 15% of pharyngitis cases are from this new bacteria that can lead to blood clots, that can lead to an abscess. So it's something that is kind of more up in the current medical journals. Okay, so now we're moving on to the common cold, which is also pharyngitis, but we just kind of separated it out, the common cold, because it's so common. So here, the common cold is caused by coronavirus, so don't forget that. It's coronavirus, there's all kinds of different coronaviruses, tons and tons. But the common cold is always a virus. If I have a cold, I have a virus. So I don't want you to, why did I want you to remember all those? The reason I wanted you to remember all of those, do I want you to remember all those? I just want you to be able to identify that the common cold can be caused by many viruses. And the only other thing that I wanted to throw out there for any of you that are going to be clinicians is that RSV is so common now. So respiratory syncytial virus, respiratory tells you it's respiratory, syncytial, it causes syncytia, and it's a virus, and now it's like moved up and up and up to where it's like second to COVID at this point. A lot of infants are getting it, and it's life-threatening for infants. It's really, really scary. Yeah.
Do RSV vaccines prevent it? Like, how many times do you have to get it? Is it like a yearly vaccine, or is that one of those
No,
where?
that's all newish. I don't know very much about RSV, but it's all new kind of information.
Okay.
So yeah, good question.
Ask my doctor.
So what I want you to know is that coronavirus is part of the common cold umbrella, and that a lot of different viruses can cause the common cold. Over 200 types of viruses.
Are all of them coronavirus, or are they all different?
No, they're all different, but there's all different kinds of coronaviruses also.
Okay.
But it's probably in the 200 are included all the different coronas, as well as rhinovirus,
Gotcha.
adenovirus, some virus, yeah. So it's what the common cold is pharyngitis as well as sinusitis. They're not typically a fever, but sometimes in small children you can have a fever as well. But the cold usually doesn't contain a fever unless it's an infant. And this is not always the case, so I don't even want to, I'll throw it out there, but don't write it down, because this is just my own anecdote. But bacterial, in my mind, I think bacteria with fevers because I think of exotoxins, but that's not always the case. Viruses can cause fevers as well because our own white blood cells can secrete toxins that lead to a fever. But I kind of think like if a patient has a fever, then I'm like, bacterial. If they don't have a fever, you're like, viral. But that's not always the case, so I'm just throwing that out there broadly. Okay, so sinusitis is a sinus infection. So one thing I just wanted to throw out there is that I didn't have you memorize mostly allergies because, you know, we're so micro-bound. We're so micro-involved in our minds of what, you know, something comes up and we're like, oh, it's a bacteria, oh, it's a virus. Well, don't forget, it's sometimes hay fever. Like sometimes they are allergic to their detergent. Like you never know really what it is, but you know, we always think like microbrain, but viral is mostly sinusitis, but it can be bacterial, it can be fungal, mostly viral. So just remember sinusitis, viral. Okay, so otitis media, this is an ear infection. So this is the tympanic membrane of the ear. So when it's healthy, it looks like the little head of a drum, which is kind of what it is, how it functions. There's the tympanic membrane, and when it's red and swollen and enlarged, that's otitis media. That's an ear infection. I get these all the time because I'm a swimmer, and when I swim, some people have a narrow ear canal and the water gets trapped in there, but some people, like for my nephew, for example, he's not really a professional surfer, but he surfs semi-professionally, and over time, because he's had so many ear infections, that it caused scar tissue, so now the water gets trapped in there no matter what he does. So the water's always trapped in there. So you have to do really take care of your ears every time you swim. And so I have to really take care of my ears also. I get water trapped in there really easily. Even in the shower, I have to be careful. But babies, because their ear canal is so small and that their parents can get water in there from the bath, or they swim in a swimming pool or something like that, babies can get ear infections really bad, but also they can get it'll start with sinusitis, and the bacteria or the virus will reach the tympanic membrane from the inside. So, so it's painful, so generally what the clinicians will tell you is there's a series of watchful waiting. So watchful waiting is they'll tell you like, oh, my baby's been crying, they're rubbing their ear, they can't sleep. They usually say wait 72 hours to see if it improves. If it doesn't improve, bring the child in. That's usually what they'll say. Some clinicians will just give them antibiotic ear drops no matter what. For me, for babies you can't do this, but for me I use rubbing alcohol, and rubbing alcohol will get rid of it immediately. But if I wait longer before I use rubbing alcohol, then it gets so bad it spreads to my face and to up into my scalp, and I can feel I have an infection spreading. So, but for babies, you have to be really careful what you put in their ears, and they'll usually give you antibiotic ear drops after 72 hours if they're still having a hard time. But also for a parent, 72 hours waiting for their child to feel better is an eternity. So sometimes I'll just give them antibiotic ear drops and just say, oh, it could be bacterial, so let's just get rid of it. So if it's bacterial, so this is kind of a new strep we haven't talked about a ton, but this is called Streptococcus pneumoniae, and it's called strep pneumo, is kind of like the nickname for it. So you'll hear about it. I'm not going to have you memorize that because it's not part of our note cards, but you'll hear about it more and more, is strep pneumo. And I don't want you to memorize it. Just know that it's commonly, otitis media generally is bacterial, but if that patient also has a sinus infection, has sinusitis, then it probably is viral, because as we go back, sinusitis is viral, and it's spread from the sinuses all the way to the tympanic membrane, and there's a viral infection in the tympanic membrane. So here, if it's either bacterial, it's probably bacterial. If it's not, if your patient also has sinusitis, it's probably viral. So just something to think about. Here's some other bacteria. Also, this is new, Candida. What is Candida? A fungus, yes. So this is a fungi that's, now we're getting worried more and more that Candida can cause ear infections as well, but I don't want you to memorize that. It's just something new that I've seen in the news. Moraxella, how do you say that? Cataralis? Catarrhalis. I don't know, yeah, that's a weird word. But Moraxella, you'll hear about this more and more. And then Haemophilus influenza, you'll hear about that one a ton, but I don't want you to memorize any of those. Just bacterial or viral. If it's sinusitis, it's probably viral. But just, the more that you see these organisms and the more you recognize them, the better it is. You'll be like, oh, I heard of that before somewhere. It just helps with your memory sometimes if you're going to be dealing with it more and more. Okay, so that's all upper respiratory. So now we'll get into lower respiratory, so the lungs. So I won't go into anatomy of the lungs, but I won't test you on it, but I'm just going to kind of show you really quickly that there's the trachea. This is the windpipe right here is the trachea. That's more anterior in the front. So anterior, posterior is the esophagus, anterior is the trachea. You don't have to know that for this class. And then the trachea so that's the windpipe, and it can have an infection. So tracheitis is rare. You don't typically get tracheitis, but probably a lot of you have heard of bronchitis, right? Have you heard of bronchitis? So that's an infection of the bronchi or the bronchioles. So the bronchus or bronchi, depending on if you're saying singular or plural, are these bigger tubes. So there's this giant tube that leads to bigger tubes, that leads to smaller tubes, smaller tubes, smaller tubes, that leads down to these little grape-like structures that are called alveoli. So these are very, very, very thin skin that cover these little grapes. Or inside of these grapes is nothing, is air. They're air pockets. They have like some white blood cells, they have some like mucus and substance called surfactant. They have some stuff in there, but mostly it's just an air-filled pocket that we fill with oxygen, but it's a single layer of tissue that covers the alveoli. These tubes are really thick tubes that go down to the bronchi, to the bronchioles, and then the alveoli, so it's just smaller and smaller branches. The lungs look like trees with grapes on the outside. Bronchiolitis, you don't really call it that. We call it mostly bronchitis, but then once it gets to the alveoli, we call it pneumonia. Or pneumonitis, you might hear of that, but most people say pneumonia. So we'll learn about, for the lower respiratory, pneumonia, influenza, whooping cough, which is also called pertussis. We'll talk more about respiratory syncytial virus and tuberculosis. I'm glad I put that on there because I think I just added that recently. Okay, so let's talk about what pneumonia is. So new lung infiltrates plus clinical evidence that the infiltrate is of infectious origin, blah, blah, blah. So what we're saying is that there's something in the lungs and that there's an infection in there. There's some organism in there. So there's two types. One, and there's a big reason why we separate these. So we have one that's called community-acquired pneumonia, and then we have one that's called hospital-associated pneumonia. It used to be called hospital-acquired, but again, they don't want to be blamed for anything. Now we're saying hospital-associated. So, oh, I put acquired on here, but it's not acquired anymore, it's associated. So there's CAP, which is community-acquired pneumonia, and then there's HCAP, which is hospital-associated pneumonia, or HAP, or I'll show you what the other option is, healthcare-associated pneumonia. Because you don't always say hospital-associated pneumonia. I'm just getting into the semantics, let me just explain it, but you don't have to know this. So the other thing is HCAP is healthcare-associated pneumonia, because not every place where healthcare takes place is a hospital, right? So healthcare-associated pneumonia is HCAP, and that is like, I got it in a clinic, I got it with my home health nurse, I got it in the skilled nursing facility, I got it, you know, something like that wasn't a hospital. Okay, so I think it's cool to read this. I think it's important for you if you're planning on going into medicine, of like what are the requirements. Also, one of the things that you might hear if you're in a hospital setting is VAP, or ventilator associated pneumonia. So if you're putting something down there, you're just asking for something to be introduced into the lungs. So if your patient is on a ventilator, when that ventilator enters into the trachea, then you're introducing bacteria, but also you're leaving that airway open to infection all the time. So that there's not a way, they try to, but there's not a way to filter the air that comes in through the ventilator. Yeah?
Is catheter-acquired pneumonia prominent for people who get like angioplasty?
Yes, yeah, so, yeah, a heart catheter or urinary catheter, they're all, yes, very common.
Urinary catheter, can they get pneumonia?
Oh, no, not pneumonia, no.
Oh, gotcha.
Infection. Yeah. Yeah, and it can be like from an endoscope or from a lung biopsy or anything like that, yeah. Highest cause of infectious infant mortality. That's interesting to know. I don't want you to know that, but just so for your own. So HAP is hospital-associated pneumonia, very, very common, 5 to 50% mortality. Community-acquired pneumonia, 3% mortality, very, very low in comparison when somebody gets pneumonia out in the environment versus getting it in the hospital. Infants, elderly.
Why would that be the case? Why would it be better? I mean, if it's the same disease, why would it matter where you got it?
Yeah, great question. So, the organisms are different.
So it's not exactly the same.
Yeah, the organisms are different. So we'll talk about what the organisms are. We'll separate them out.
Okay.
And then also, when one healthcare worker is bringing in infection to room, they're at higher risk for pneumonia. But also, there was one more point I wanted to say about that was, that they're non-ambulatory, so they're higher risk for pneumonia
if they're in the hospital.
Mhm. Yeah. Okay, so here's community-acquired pneumonia. Here's what I want you to know, 2 things, that if it's viral, so this is exactly what Dr. Myers was saying, what Dr. Dominicus was saying before, which was a good point, was that before SARS-CoV-2, we didn't really stress about viral pneumonia as often. Bacterial pneumonia, we worried about a lot. But now, if it's SARS-CoV-2, we really do worry about viral pneumonia a lot as well. So, viral pneumonia can be community-acquired, bacteria, if it's bacteria. So, this is the number 1 that's shot way up in comparison. Yeah.
So are you saying that if you have viral community-acquired pneumonia, it will be SARS-CoV-2, or are you just saying that's the worst one?
That's the most common.
Okay.
Yeah, that's the most common. And then bacteria is most likely strep pneumo out in the community. This was most common pre-COVID. It's an alpha hemolytic. You don't have to know any of that. You don't have to know the name strep pneumo because it's not part of our cards. But bacterial, first most common is viral because of coronavirus. The second most common is bacteria. Without coronavirus, bacteria outnumbers 10 to 1. Okay, so Klebsiella pneumoniae, I don't want you to memorize any of these also, but I know that I've seen that on the T's. And then influenza we'll talk about separately, but coronaviruses, RSV, adenovirus, we'll talk about more about those. Okay, so other ones for community-acquired pneumonia that I don't want you to memorize, but just to mention them just as you're hearing about it, that atypical pneumonias, or sometimes it's called walking pneumonia, are just a more mild case of pneumonia from these organisms. So these are both bacteria, mycoplasma, and I've never heard of that one, chlamydiophilia. I've never heard of that. But these are bacteria. And another problem that we're worried about more and more is fungal pneumonia from histoplasma. So this can be from bird and bat droppings from people who live there, but also in the Midwest and in the southern states, they can get fungal pneumonia. You don't have to memorize any of this. And then the other one that's we're worrying about more and more is called PCP, is pneumocystis jirovecii, and that is called PCP fungal pneumonia, and it's common in immunocompromised patients. But you don't have to know any of those. Okay, so let's talk about SARS-CoV-2 a little bit more. We've talked about it kind of a lot, and I know you guys probably get so sick of hearing about it. And I was sick of hearing about it before I started teaching this class. Even I was like, I don't want to talk about COVID. Everybody's so sick of talking about it. But the reason I kind of bring it up more frequently is because I realized how much people don't know about it. Everybody knows about it, but nobody knows what it is. Nobody really knows about it. So I think it's important for you guys to be out in the public knowing, what is this? What is this virus? What does it do? What does it look like? What is it? Where is it common? Where are you going to see it? Where a lot of people don't know that. So remember that SARS-CoV-2 stands for Severe Acute Respiratory Syndrome, coronavirus, number 2. The disease, so that's the name of the virus. The name of the disease is COVID-19, coronavirus 2019. It was first identified in Wuhan, China. It spread rapidly around the world because it's a zoonotic, because it went through antigenic shift, and it was crazy worldwide. We had no way of controlling it. We didn't know where it came from. We didn't know how it spread. It started off extremely severe, and now that it's gotten less and less severe with as the mutations have gone through some rounds. Yeah, go ahead.
So would pneumonia be a sequelae of COVID-19? Am I using that right?
That's a good question. So pneumonia is the infection of the lungs themselves. So a sequelae would be a long-term consequence of a SARS-CoV-2 infection. So your patient has coronavirus, and then 3 months later is still having heart issues, and that's the sequelae. That's the consequence of having that infection. Yeah, so they're having like the virus got into their endocardial tissue or the pericardial tissue, or the virus got into somewhere else where it's like people have had like chronic sinus infections, or they have headaches or things like that that can be sequelae from having that original pneumonia from the SARS-CoV-2. Or they can get pneumonia. So I wouldn't say pneumonia is really a sequelae, because sequelae is more like, I wouldn't say like, it's not a permanent thing, but I'm trying to define it for you, because I see what you're saying. Because if you started off with like pharyngitis, for example, I see what you're saying. So if you start off with pharyngitis from SARS-CoV-2, and then you get pneumonia from that. That's more of like something, an acute thing. It's not really considered long-term until it's like, I'm not sure what the time limit is to consider a sequelae, but it's more like I have this long-term problem because of my original infection. Yeah, good question. Okay, so it's a zoonotic, enveloped, helical capsids. We can go back over that before we go over the final. It triggers degranulation from mast cells and basophils. They're called bradykinins. These, I don't want you to memorize that. It can block interferon production, which is crazy. So interferon, remember, was what cells will release when they have an infection inside of them. It can block the release of interferons, which is nuts. And then we have a new mRNA vaccine that, what was her name? Dr. I can't remember her name now, but she's the one who helped launch the mRNA vaccine. We're going to use those more and more. And it starts usually as a respiratory, but it can get into the blood, heart, kidneys, lungs, all that kind of stuff. Okay, so this is what we're going to remember. Pneumonia, that we're going to remember what the name of the virus is. We're going to remember what the name of the disease is, and we'll keep it mellow.
But other things can cause pneumonia besides
Yes.
COVID.
Yes, so here's what can cause pneumonia in a community, and then we'll go over in the healthcare next. Yeah. So here's hospital associated or healthcare associated. So 1% of all hospitalized patients, which I thought that was kind of low. I've seen that more, but it probably depends on the hospital. 30 to 50% mortality, incredibly high. Ventilator-associated pneumonia is common. Bacteria is the most common. So bacteria is what we worry about in a hospital setting. So I want you to remember is that bacteria, they flip-flop. Bacteria we've always worried about forever. Now since COVID, we worry about viral first in the community. We still worry about bacterial in the hospital. So viral in the community, bacterial in the hospital. Yeah.
On the other slide, it said 3 to 50% for hospital-acquired specifically. Do you happen to know if like the higher number is more accurate or the lower number is more accurate?
Which one?
When you
I
had the
thought that
slide.
sounded low.
Yeah, there was the one that was defining the different types right here at the bottom there. It says 5 to 50% next to hospital
Mortality?
associated. Right, and then on the other slide, it says 30 to 50.
I have 5 to 50 or healthcare associated. Is it because it is 1% or so? I bet what the difference is in those are whether it's hospital associated or healthcare associated. Because in a hospital setting, there's the emergency department, there's ortho, people who break their legs, there's people who have vasectomies, there's people who have, like all kinds of different people in the hospital for different reasons. But if you include healthcare, then you're including skilled nursing facilities. And when you include skilled nursing facilities, I can imagine that number skyrockets.
Would you also be including people who are on hospice and stuff in their own
and
home?
home health,
Mm.
yes, is healthcare associated. I would imagine that they would include all that in the data, yeah.
That's why it's higher on the other one.
Yes,
Okay.
and skilled nursing probably is the huge part of it, because skilled nursing facilities are the geriatric patients, the old elderly patients that you really worry about pneumonia a lot, yeah. Okay, so let's talk about influenza. So influenza is a virus. This is one of our note cards as well. That's all I wanted you to know, that influenza is a lower respiratory infection. But also it can cause all kinds of different stuff. So flu-like symptoms, mutates each year, H1N1, we'll know about that for the final, we'll know the zoonotic for the final. So it can be an upper respiratory infection. We put it into our lower respiratory group, but also they have so many different tissue tropic areas, influenza does. But one thing that I thought was interesting was body aches. So, you know, that's me. When I have the flu, I know immediately it's the flu because my joints hurt so bad. And like immediately I'm like, it's not a cold, it's not anything. I know it's the flu because I get like joint pain. And some people get like body aches and just feel all around terrible because there's a cytokine overload from this virus causes, and you don't have to memorize this, none of this, don't memorize any of that. I just thought it was interesting, was that they're called interleukins, and it causes this flood of interleukins. And this same interleukin is a cause of, so if elderly patients who get UTIs, when a patient that's elderly gets a urinary tract infection, it can look like they had a stroke. You're like, oh my gosh, my patient is slurring their words, they're not making sense anymore, they're tripping, something is wrong, they're having a stroke. So you take them 911 to the hospital and they're like, oh, they have a bladder infection. And this is common for elderly patients. It's extremely common for elderly patients. One, because elderly patients get UTIs regularly. They don't drink enough fluids, they're dehydrated, the hygiene problem, like Dr. Myers and I were talking about earlier, is they have hygiene issues. So they can get E. coli infections really easily in the bladder. And it causes this IL-6 overload, and that IL-6 overload can cause it looks like a stroke. It affects the brain to where it seems like they had a stroke, which is crazy. So I just thought that was interesting, but you don't need to know any of that.
Are interleukins, like, is that the type of leukocytes?
So interleukins are released from leukocytes. There's the cytokines. So all of our leukocytes and lymphocytes will secrete cytokines. And cytokines are just a chemical to call in other white blood cells. It's just, they actually, what they'll do is they'll like trigger white blood cells to activate or trigger them to deactivate, things like that. But also they can turn up the immune system or turn down the immune system. So what they're doing is that it's like there's too many of them and they're overloading the immune system. And then the immune system secretes all their interleukins, which can cause brain. Yeah, which are the cytokines, yeah. Okay, so let's talk about whooping cough or pertussis. So this one, it's annoying, it has two names, it just does. But this one I think is important to know because it's common and also it's part of the Tdap or DTaP vaccine that a lot of people get. So both of my nephews had pertussis and they had like a 6 month to 8 month cough. It's so annoying, and it's like a seal cough, like a real wet, heavy seal cough. And they don't sleep very well. It's annoying. It's a really difficult infection to have. But it's from a bacteria that's called Bordetella pertussis. So the things I want you to know is just that it's called whooping cough and pertussis, and it's a bacteria. But one thing I think is important for you to realize is that what the DTaP and Tdap is if you're going into this area of clinical medicine. So diphtheria is a bacteria. Tetanus, we talked about what tetanus is, that's a bacteria. And it's called, the A stands for acellular pertussis. So it's a bacteria, but they usually give it, it's like a toxoid vaccine, acellular. It's not the actual bacteria itself that they give you. I don't know why they stick in the A, but yeah.
So what your thing up there says is Tdap for adults is anytime for those who have never received it. But for some reason in my head, I'm thinking, aren't you supposed to have a tetanus booster every 10 years?
Yes, you are supposed to get the tetanus, but they do the tetanus by itself as well. So you can get the tetanus by itself, or you can get it as part of the Tdap.
I see.
Yeah. So it helps you to understand where these come from and what they are. So diphtheria is very, very rare. It's respiratory. Tetanus, we talked about what that is. That's the chronic tonic contraction, the muscular contraction. And then pertussis is lower respiratory bacteria. Okay, so respiratory syncytial virus. This is that's all I want you to know. It's a lower respiratory infection, respiratory syncytial virus. but this is, I put 100% of the population, so at some point, everyone's had RSV. Most cases are mild, but in children, we really worry about RSV more and more. This is gonna take over as the new fear and, you know, what we worry about a lot for children. More than 100,000 children hospitalized per year. I think that's like doubling per year. At this point, it's crazy. But this is what a syncytia is the virus will degrade the tissue between the cells, and the cells turn into one big clump of a cell so that it can hide from the immune system. So it has syncytia in the name, so that helps remind us about that cytopathic effect of viruses. Yeah.
Question about the Tdap. Is there a relationship between those bacteria and like why would they put them all in one vaccine?
That is the question of the year. I ask myself that all the time. Yeah, I don't know why. You know, what they're trying to do now is shove as many as they can into one to encourage people to get one and not have to get so many. But at the same time, you know, it's a lot on the immune system. It's a lot, you know, so I don't know. I think what they try to do is encourage patients to get them done. So in my opinion, I don't like that because, you know, what they're doing at the newborn checkup and like the early checkup of children, they inundate them with all of the vaccines because they're less and less likely to come back as they're older. So they just are giving them all the vaccines right up front, and so it's just a huge load on your child's immune system all at the same time. So there are ways to do it, but you know, don't take it out. I looked at exactly how many she needed, because sometimes if you're like, after 2 months they only need 2 versus before 2 months they have to have 4, so they'd have to get 2 and then 2 more. So I'll just wait and get her 2 more. But at the same time, then you have to be really careful if your child's around and all that kind of stuff. So it's a whole thing. Sorry, I just went in the deep end. But yeah, they do clump them together, I think optimally, to get them all done at the same time so they don't have to come back in, and they're getting more and more shots as well. Yeah. Okay, so tuberculosis, we've talked about this one a ton. I think it's important to talk about a lot, even though it's not really active in our lives, because a huge population of the world has it. Mycobacterium tuberculosis, these are all good reviews, even though I just highlighted what you need to know for the quiz, not what you need to know for the final. So that's easy. We need to know Mycobacterium tuberculosis, we need to know it's a bacteria. For the final, we need to know all this stuff. We need to know it's gram, we don't know. It's acid fast, that helps us remember here for acid fast is here. So acid fast, what color were remember they look really weird. They look like this, like really long, weird looking bacilli. Carbofusion. Yeah, so these ones were the hot pink ones. These ones were the green ones. Yeah, so these are the hot pink. That's carbofusion. Those are, we don't know what gram they are because they have that mycolic wax on the outside. That mycolic wax is what makes them stick to this lower respiratory tissue. They're aerobic, they need access to oxygen. They form these little things called pulmonary granuloma. A granuloma is just another word for like a tumor. We call this caseous necrosis because these are all white blood cells. It hides within white blood cells. How smart is that, right? It hides within neutrophils. The neutrophils go to attack it, and then it sticks all the neutrophils together into a big clump. So the immune system can't access it. The immune system only sees neutrophils. So it's, you know, it's crazy how these things have evolved over time. It's latent, but we don't really consider it a provirus because it doesn't attach to the DNA or incorporate into the DNA at all. It's a provirus because it lasts a really, really long time. It's really difficult to get rid of, but it doesn't do anything with the DNA. It just hides in the white blood cells. Yeah, go ahead.
What does latent mean again?
Latent means like dormant. It's like you have it for a long time and you can have it without symptoms.
So people can have it. Is that why they do the PPD test?
Yes, that's why they do that. I'll show you what a PPD is, yeah, Yeah,
Got
yeah.
one yesterday.
Oh, yeah, you got it yesterday? Hey, that's a coincidence. Oh, crazy. Okay, so a huge percent of the world's population has it. 5 to 10% develop symptoms, which seems low to me, but they, can have bouts of coughing and it can go away, bouts of coughing and it can go away. But that it's so, any kind of coughing and the mycobacterium can live on respiratory droplets, so it's extremely easy to catch person to person. Able to survive 8 months on air particles, it's nuts. Okay, so a PPD, and I'll explain what a PPD is, even though I don't care that you know this. I just thought if you think it's interesting, because all of you will have to do this if you work in a healthcare setting. So what a PPD stands for is purified protein derivative. So now that we know a little bit about vaccines and about organisms, what do you think purified protein derivative means?
Pieces of
It, yes, kind of like a conjugate vaccine. It's like just a piece of it. So what, when you inject a piece of it, what do you think we're looking for?
a reaction.
A reaction. Why would we have a reaction? Antibodies. Yes. So we would have antibodies that would attach to that protein derivative because our bodies have seen it before. Then you have antibodies that attach to that protein derivative, and then you have a whole. Now they're opsonizing, and they're agglutinating, and they're activating, and there's a little local infection. It won't go into the lungs. It won't cause tuberculosis because it's just a piece. But because of that piece, there's a recognition from the antibodies that will cause a little mini infection, and that little mini infection would signal like, oh, your body has had tuberculosis.
So I don't want it to look like that because then it'll mean I'm not a latent carrier.
You don't want it to look like this because it means you have tuberculosis or have had it at one point. You want it to look like this.
Okay.
Yeah. So how's it look?
Looks fine.
Looks good. Okay, you're good.
I think
Okay.
so.
You're all, huh?
No, it looks pretty good. It's a little red, but.
Okay. That's okay, that's normal. Okay, so that is it for respiratory. So what we're gonna do now, does anybody have any respiratory questions? We're doing good, so cardiovascular, respiratory.
I have one question.
Yeah. Oh, sorry, go ahead, Dr. Duffy, sorry.
Just on the last slide, what's an air particle?
An air
What do they mean by
particle?
like an air particle?
Yeah, so like respiratory droplets, so because respiratory droplets, it's like spit. It's like air, like, there's like air particles, like even on dust, bacteria can live on dust. So for example, if like we all left the room and we left an agar plate open and we just left it and everybody left the room, there would be bacteria on the plate because there's bacteria on air particles, on dust and air particles. But if we're breathing near something, it can be on our respiratory droplets. And on those respiratory droplets, the bacteria can exist on those tiny, tiny little spit droplets.
For 8 months?
Yeah. Crazy. Mycobacterium is very hardy because it has that mycolic wax, so it's like,
That's crazy.
can live a long time. Yeah, very crazy scary. Yeah, so, there's so many people that have it. When you go to like over here, if you see this tiny little map, here's Kenya. Right over here, there's so many people that have it. And yeah, I mean, you just have to be careful not to let people cough on you. Yeah.
Have we just not found a way to take off the mycolic wax around it to find out what gram it is?
Yeah, I don't know if they know what gram it is at this point. They might know, somebody might know, because now we have so many tools and techniques that are more precise, like the precision and being able to look at, have you guys heard of a mass spectrometer? Yeah, a mass spectrometer is a mass spec, and so they probably would know at this point, I would guess, if they're, how much peptidoglycan it has, and be able to compare it. Yeah, but that's a good question. But also, I'm sure there are labs all over the world trying to figure out how to also like get rid of mycolic wax so that they don't stick in the lungs. Yeah, this is a huge thing that people work on all over the world. Yeah. And malaria as well. It'd be cool to work on a malaria team or tuberculosis team, something like that. Awesome. Okay, so what we're gonna do now is I am going to leave you guys in here until 2:30. And then I want you to take a 10-minute break. But you can also keep working until let's get started at 2:45. So we're gonna get started at 2:45. Well, how long do you guys think? Do you guys wanna vote on that? How long you want? Because we